What if the sudden anxiety, the restless nights, the unexplained irritability, and the quiet pull toward a glass of wine at the end of the day are not signs of weakness, but signals from a changing brain? For millions of women entering their 40s and 50s, menopause and perimenopause are not simply biological milestones. They are neurological transitions that reshape emotional regulation, stress response, and even the way reward feels in the body. This is not merely about hot flashes or irregular cycles. It is about dopamine pathways, serotonin modulation, and the profound influence of estrogen and progesterone on the brain's delicate chemistry. As estrogen fluctuates unpredictably during perimenopause, its regulatory role over dopamine signaling begins to shift. Dopamine, the neurotransmitter associated with motivation, reward, and reinforcement learning, becomes less stable. At the same time, serotonin systems, which support mood balance and emotional steadiness, may also become dysregulated. The result is not just discomfort. It is a neurobiological storm that can heighten anxiety, amplify stress sensitivity, disrupt sleep architecture, and erode emotional resilience. When sleep is fragmented and stress thresholds drop, the brain instinctively seeks relief. Alcohol may appear soothing. Sedatives may promise rest. But what feels like relief is often the brain attempting to rebalance itself through external chemicals rather than internal adaptation. In this life stage, women are not imagining their increased cravings or emotional intensity. These experiences are rooted in measurable hormonal shifts that influence the limbic system and prefrontal cortex. The brain's reward circuitry becomes more vulnerable when estrogen declines sharply, and stress hormones such as cortisol may remain elevated longer than before. This combination creates a powerful feedback loop. Heightened stress increases craving, substances temporarily dampen discomfort, and the brain gradually recalibrates to expect that external relief. Over time, this can subtly increase vulnerability to substance use disorders, particularly alcohol and sedative medications. Research in behavioral neuroscience has shown that fluctuating ovarian hormones alter sensitivity to reward cues and stress triggers. This means that a coping mechanism that once felt occasional can begin to feel necessary. The narrative that midlife women are simply coping poorly misses the biological reality beneath the surface. Thought leaders such as Dr. Anna Lembke, known for her work on addiction medicine and the neurobiology of reward, have emphasized that the modern brain is exquisitely sensitive to dopamine-driven behaviors. When hormonal fluctuations destabilize that system, the search for equilibrium intensifies. The brain does not distinguish between a pharmaceutical sedative and a glass of wine when it is seeking homeostasis. It responds to dopamine release and relief from discomfort. Understanding this mechanism is not about blame. It is about empowerment. When women recognize that perimenopausal changes directly influence stress circuitry and craving pathways, they can shift from self-criticism to strategic action. They can ask better questions about sleep hygiene, hormone therapy, stress management, and evidence-based medical interventions. Instead of silently increasing alcohol intake or relying on nightly sedatives, they can view these urges as data, signals that their neurobiology is adapting to a new hormonal environment. The transition through menopause is a recalibration, not a collapse. But without awareness, that recalibration can unintentionally open the door to dependence. The key is recognizing that the brain in midlife is not failing, it is changing, and with informed, intentional choices, it can regain balance in powerful and sustainable ways. As this hormonal transition deepens, something subtle yet powerful begins to unfold beneath the surface, and most women are never warned about it. The fluctuations of estrogen and progesterone do not simply influence mood in a general sense. They recalibrate the brain's stress circuitry and alter how intensely discomfort is experienced. Estrogen modulates dopamine transmission in the mesolimbic pathway, the very circuit responsible for motivation and reward anticipation. When estrogen levels swing unpredictably, dopamine signaling can become erratic, which may leave ordinary pleasures feeling muted while stressors feel amplified. At the same time, progesterone and its metabolites interact with GABA receptors, which are central to calming neural activity. When progesterone drops, the natural calming effect weakens, and the nervous system can feel persistently on edge. This combination can create a psychological landscape where anxiety rises more quickly, sleep becomes fragmented, and emotional regulation demands far more effort than it once did. In that state, the brain begins to scan for rapid relief. Alcohol, sedatives, and even certain prescription sleep aids can appear to restore equilibrium, at least temporarily, because they artificially stimulate the same inhibitory or reward systems that hormones once helped stabilize. However, what seems like a harmless coping strategy can quietly shift into reinforcement learning. Each time a substance reduces discomfort, the brain encodes that behavior as effective. Dopamine release strengthens the association between distress and the external solution. Over weeks and months, tolerance may develop, meaning that larger amounts are required to achieve the same effect. Meanwhile, sleep quality often deteriorates further, because alcohol suppresses REM sleep and sedatives can disrupt natural sleep architecture. The result is a cycle in which the original symptoms of perimenopause, fatigue, irritability, mood swings, become intensified by the very substances intended to relieve them. This is where suspense enters the story, because many women believe they are managing their stress responsibly, unaware that the neurobiological terrain has shifted beneath them. What begins as a single nightly drink can gradually become 2 or 3, justified by a demanding career, caregiving responsibilities, or chronic exhaustion. The vulnerability is not a character flaw. It is a convergence of biology and behavior. Research has documented correlations between the perimenopausal transition and increased alcohol consumption, particularly women experiencing untreated depression or high stress loads. The stress response system, governed by the hypothalamic pituitary adrenal axis, can become more reactive during this stage, prolonging cortisol elevation and intensifying cravings for quick relief. The brain, striving for homeostasis, may interpret substances as tools for stabilization, yet the adaptation comes at a cost. Over time, the reward threshold shifts, and natural sources of pleasure, exercise, social connection, creative work, may feel less potent compared to chemical stimulation. The deeper risk lies in the normalization of this pattern. Because midlife women are often high-functioning and outwardly successful, increasing substance use can remain invisible for years. The internal narrative may say, "I deserve this," or "This is the only way I can sleep." But beneath that narrative, neural pathways are strengthening in ways that can lead to dependence. The suspense is not dramatic or explosive. It is gradual and quiet. It is the slow recalibration of a brain that once regulated itself differently. Understanding this process does not create fear. It creates awareness. Awareness interrupts automaticity. When women recognize that hormonal shifts are interacting with dopamine, GABA, and cortisol systems, they gain the power to intervene before patterns solidify. The question is not whether discomfort will arise during menopause. It is whether the response will build resilience or gradually outsource regulation to substances that ultimately destabilize the very systems they temporarily soothe. The turning point begins the moment a woman understands that what she is experiencing is not personal failure, but neurobiology in transition, and that knowledge alone can dismantle shame while restoring agency. When hormonal shifts alter dopamine sensitivity and stress reactivity, the solution is not willpower alone, it is informed intervention. Evidence-based medicine offers options that align with physiology rather than fighting against it. For some women, carefully supervised hormone therapy can stabilize estrogen levels and reduce the volatility that intensifies mood swings, sleep disruption, and cravings. When appropriate and medically evaluated, restoring hormonal balance can indirectly steady dopamine and serotonin systems, creating a more predictable emotional baseline. For others, non-hormonal pharmacological treatments targeting mood or sleep may be indicated, particularly when anxiety or depression becomes clinically significant. The essential principle is precision. Symptoms deserve targeted treatment rather than self-medication. At the same time, lifestyle interventions are not superficial recommendations. They are neurobiological tools. Regular aerobic exercise increases endogenous dopamine and supports neuroplasticity. Strength training improves metabolic health and stress resilience. Consistent sleep schedules reinforce circadian rhythms that alcohol often disrupts. Mindfulness practices reduce hyperactivation of the stress response system, lowering cortisol and enhancing prefrontal regulation over impulsive behaviors. Nutritional stability, especially adequate protein and omega-3 intake, supports neurotransmitter synthesis and brain integrity. These are not generic wellness suggestions, they are strategic recalibrations of the brain's reward and stress circuits. When women replace nightly alcohol with structured wind-down rituals, social connection, or cognitive behavioral strategies for insomnia, they teach the brain new associations. The reinforcement loop shifts from chemical relief to adaptive coping. Over time, dopamine pathways can recalibrate, and natural rewards regain their potency. This is where empowerment becomes practical rather than abstract. Instead of asking, "Why can't I handle this?" the question becomes, "What does my brain need in this phase of life?" Thought leaders in addiction medicine, including Dr. Anna Lembke, have emphasized that repeated exposure to high dopamine stimuli lowers the baseline of pleasure and increases the experience of pain or dissatisfaction when the stimulus is absent. In the context of menopause, where hormonal fluctuation already destabilizes reward processing, this dynamic can accelerate. But the same neuroplasticity that permits vulnerability also permits recovery. The brain is adaptable across the lifespan. Women over 40 are not neurologically fixed, they are biologically evolving. That evolution demands informed strategy, not silent endurance. Seeking professional evaluation for mood changes, discussing hormone therapy candidly with qualified clinicians, and tracking patterns of alcohol or sedative use are acts of strength. They reflect accountability and foresight. The deeper message is that menopause is not merely an ending. It is a neurological reset that requires recalibration. When women approach this phase with education, community, and medical guidance, they reduce the risk of dependence and enhance long-term vitality. They reclaim authorship over their health narrative. The discomfort of transition can become a catalyst for deeper self-awareness, disciplined habits, and resilient coping structures that extend into the decades ahead. Biology may shift, but agency remains. The brain may fluctuate, but it can also stabilize with the right inputs. No woman is destined to self-medicate her way through midlife. With clarity, science, and deliberate action, balance is not only possible, it is sustainable. If you are benefiting from our topics, please subscribe, like, and turn on the bell notification so you can see our new videos early.